Hi everyone, this is Daniela from the Obstacle Doc, and today we're going to talk about IT band friction syndrome and why it can come on and possibly how we treat it. So the IT band in and of itself is a band of fascial tissue, connective tissue that runs from the hip down to the knee. It goes just below the knee onto the outside of your tibia, your shin bone. So if I'm talking about outside of the knee, up to the hip. It is actually a long tendon, if you will, from the TFL, which is a hip muscle, your tensa fasciolata, and it comes from the TFL as well as some of the fibers of the glute max, and then weaves into this thick band that comes down into that tibia. When we hear an IT band complaint, usually it is an acute onset, so it seems sudden, but there's generally a insidious progression to its irritation. This is usually a volume issue. So if you're going from no movement, very little movement, to a lot of exercise, maybe you're increasing your mileage. This is common in runners. It can also be you're going up and down stairs a lot. That can start to bring in some discomfort to the IT band that all of a sudden will present as a maybe sharp, maybe burny discomfort along the outside of the knee. So when we're looking at clients in the office, what we can start to appreciate just based off of stance is really where their kneecap is kind of falling. So in an ideal world, that kneecap's going to be facing straight towards you. But if we start to notice that there's any kind of internal rotation of that knee, that headlight's kind of pointing inwards, that is going to tell us some information, because as you internally rotate from the knee, you're going to be pulling some tension onto that IT band. This is just one really long lever arm. So this internal rotation moment can be either coming from the hip, so hip weakness in external rotation, or it can be coming from the foot where the foot's falling in. Maybe there's not a lot of dynamic arch support through movement, and now we're falling down from the bottom. Ways that we can test this through movement. First, easily is going to be through a double leg squat. So if Christopher goes down into a squat and he's unable to keep this external rotation moment, he's going to fall in. The space between his knees is going to kind of close. So go back up and take another couple. So as we see him, those knees kind of coming together instead of staying in this nice externally rotated fashion. That can be an indicator of some hip weakness through the top. If you come up to a single leg stance, this is also more important for our runners, for our stairs, that volume overuse injury, because as we take a step down or squat down with the single leg, this is very telling of when you're coming into a stride for your running. So as you can see, his lovely demonstration of internally rotating here, his knees falling in. This is kind of taking more of an angle, right? Perfect. That is telling us that there's something potentially happening up through the hip that is pulling now into that tension for the IT band. Similarly, just like how the hip can be the driver for that internal rotation, the foot can also be implicated. If we're seeing a lot of kind of wobble to the medial side, that inside of the foot where his pinky toes are almost coming up, his arch is kind of falling in. This can also be an area of weakness in his whole system, right? If your foot's touching the ground first and this is caving, that's going to pull this knee inwards. So easy ways that we can start to assist our clients with progressions or strength for either of these is if we have you go down into that squat again, and if I manually maintain either just with a gentle touch here, come back up, or if I manually externally rotate his femur, have him come down and come back up. And if that is more comfortable for the knee, that's telling us information that we need to get a little bit more stability through the top or through the bottom. So if you've ever had IT band friction syndrome or been told that you have some IT band pathology, you might have been told to foam roll or to stretch. While there's nothing necessarily wrong with those modalities, we want to make sure that we're aiming them in the right areas. So if we're doing any passive stretching or foam rolling, what we actually want to target is the muscle at the top of the IT band instead. So your TFL, which is going to sit right here at the top, or if you turn to the side, your glute max, which is this whole rim area. Getting foam rolling in through this area or trying to stretch this is actually going to get you more bang for your buck than trying to stretch the IT band, which itself is a really thick band of tissue that's fairly immobile, which is a point of controversy. But that's going to desensitize the tissue a little bit if you're doing foam rolling on it. But again, most of your benefit's going to come from here. The other thing we want to appreciate is why there's tension in the first place. Usually we're not born tight or with tone unless you have some sort of neurological disorder. So when we see people who are maybe experiencing this, we want to understand if this is coming from a strength deficit or overuse of that muscle. So that's going to be the first thing that we try to appreciate. But again, passive modalities can be beneficial. Stretching, foam rolling here, dry needling, soft tissue mobilization, as well as appreciating what the foot is doing, if there's anything that we can do from a dynamic arch standpoint or orthotic, shoe adjustment. Again, this is our runners, our overuse injuries, are going up and down the stairs. So taking a full leg approach is going to be more beneficial for you, the clients, if you're experiencing any IT band syndrome.